All right. Welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for Community Health at Atlantic Health System. Today's webinar, Advances in Diagnosis and Management of Atrial Fibrillation, is presented by Dr. Jonathan Sussman. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or the chat for comments. We will try and get through all questions at the end of the presentation. At Atlantic Health System, we encourage everyone to be an active partner in their healthcare. We recommend using an online tool called MyChart to help you manage your care. MyChart is an interactive tool that gives you 24/7 access to your electronic medical record. Anyone who is a patient with Atlantic Health System can open a MyChart account. This includes anyone who has visited an Atlantic Health System provider for routine visits, vaccine visits, or even an Atlantic Health System emergency room visit. If you are not a patient of Atlantic Health System, you may have access to MyChart or similar platforms through your usual provider. MyChart allows you to manage many aspects of your healthcare. Some of the most popular features allow you to request your medical records, access your medical information, test results, medications, allergies, or diagnosis, send non-urgent messages to your provider's office to request medication refills or ask questions, view your clinical notes and after-visit summaries, schedule appointments online, e-check-in for appointments, which makes the check-in and rooming go much faster. This also includes the ability to e-sign certain documents. View and pay your hospital bills online. Share your MyChart with family and friends and vice versa. For example, you can get access to your child's MyChart so you can manage the whole family from one account. Senior parents can also give access to their adult children. If you want to set up a MyChart account, need help logging into a current account, or have questions about how to use MyChart, there is help available 12 hours a day, 7 days a week. We recognize the fear, uncertainty, and confusion that surrounds making decisions related to musculoskeletal pain. In a sea of information overload, it's hard to know what's what and where to go for orthopedic care that you need. Atlantic Health System has your back the entire way. When you've got questions, we've got answers. And I am now going to turn things over to Dr. Sussman.
Thank you. So my name again is Dr. Jonathan Sussman. I'm a cardiac electrophysiologist. We're the specialty within cardiology that deals with heart rhythm issues particularly. And atrial fibrillation is one of the more common abnormal heart rhythms that we work with. And September is Atrial Fibrillation Awareness Month, so timely that we're doing this talk today. So some facts about atrial fibrillation. It, again, is one of the most common abnormal heart rhythms. Estimated that currently somewhere between 3 and 6 million Americans have atrial fibrillation. By the year 2030, which is really not far off, the CDC estimates that number will grow to 12 million. So a very common and very rapidly growing condition for reasons we don't entirely understand. Among those over 65 years old, about 9% have atrial fibrillation. And it's estimated that for any individual, the lifetime risk of developing this is roughly 25%. So really extremely common. And I hear this all the time from patients who have atrial fibrillation, say they really hadn't heard of it before, but they mentioned it at work or at a social event. And it seemed like half the people there said, oh yeah, I have that too, or my spouse has that. So really something very common that touches a lot of lives around us. Now, to talk about atrial fibrillation, we're going to take a step back and talk about how the heart rhythm works so we can make sense of what this rhythm does. So here's a cartoon picture of the heart, and it's drawn as if it's someone facing us. So you have the right side chambers to one side of the screen, left side on the other. The right atrium, top right chamber, left atrium, those are the upper chambers of the heart, and the two ventricles are the lower chambers. The left ventricle really does the hardest work, sending blood out to most of the rest of the body. So the heart rhythm is driven by electrical activity. The electrical system of the heart starts with the sinus node in the top of the right atrium. That sends out an electrical pulse at a rate of, say, 60 or 70 beats a minute. That activity spreads through the upper chambers and they beat, then down to the lower chambers and they beat. Now, all these heart muscle cells that respond to that activity can trigger their own abnormal activity. And this happens all the time. Virtually everyone has some abnormal heartbeats from time to time, more commonly from the upper chambers, sometimes from the lower chambers. Sometimes people feel these, very often not. And they're generally not of great concern, but these kind of extra beats are there commonly. Sometimes these areas that trigger extra beats at times start triggering more sustained abnormal activity, leading to abnormal heart rhythms. So atrial fibrillation is a rhythm where you have rapid chaotic activity in the upper chambers that drives the upper chambers to beat very fast at rates that might be 400 or 500 beats a minute, but very ineffectively. And that's in this cartoon here. All those squiggly red arrows in the atria represent different waves of activity through those chambers, but completely uncoordinated and very fast. Now, the rapid activity, some of that gets conducted down to the lower chambers and makes the lower chambers beat usually fast, but most of all to beat very irregularly. And that's really the hallmark of atrial fibrillation, is that irregular activity in the lower chambers. Most typically is fast, but some people's AFib is slow, and some people have AFib at the same normal heart rates that they would have otherwise. And that has a big impact on symptoms and risks related to atrial fibrillation. Now, why do people develop atrial fibrillation? A lot of the cause is not entirely understood. As I said, people have these abnormal extra beats all the time, for really no reason, and sometimes these lead to other rhythms. Sometimes there are things that we know contribute to AFib. Some of the risk factors for AFib include age, high blood pressure, obesity, diabetes, some other cardiac conditions, congestive heart failure, ischemic heart disease, where you have blockages in the arteries feeding the heart muscle, other structural heart disease, abnormalities of the heart valves or the heart muscle, certain other medical problems like kidney disease and sleep apnea, and alcohol use, even in very modest amounts, is a huge trigger of atrial fibrillation. Now, some of these risk factors can be managed in ways of varying degrees of ease. Alcohol use, I always recommend to my patients to stop or at least cut down on alcohol use. Even those who drink very modestly, the less alcohol, the better. Obesity, we encourage patients to lose weight. It's not easy. There are some new treatments in that realm. Good management of diabetes and hypertension. Those are also not easy, but achievable. Some of these other problems we cannot eliminate, some structural heart issues, but the best management for all these other medical problems helps with the management of atrial fibrillation. Now, some of the consequences of atrial fibrillation have to do with understanding them as relating to how I describe the heart rhythm working. So there's risk of a stroke, and that comes largely, we'll talk a little more about this later, but the risk of stroke comes from the atria, the upper chambers being in this chaotic state. They're not pumping well, blood's not moving as quickly as it should. And blood that doesn't move quickly will tend to form into clots. Those clots can travel out into the circulation, block blood flow to the brain and cause a stroke or cause damage elsewhere. AFib creates a risk of weakening the heart, what's called a cardiomyopathy. And that's because if the lower chambers are going fast, they will tend to get weakened. Sometimes even if the rate is not so fast in AFib, just the disorganized activity can lead to that weakening of the heart. There can be symptoms of AFib. Some people feel palpitations very strongly. Some people feel weak, tired, short of breath, or lightheaded with atrial fibrillation. Some people have very mild symptoms or no symptoms at all of atrial fibrillation. And that, of course, factors in to our choices of treatment strategies. There's some evidence that there's an increased risk of dementia in people with atrial fibrillation. Outside of the risk of any strokes or any physical injury to the heart, there seems to be some impact on dementia that's not entirely well understood or worked out. And there does seem to be a decreased longevity for those with atrial fibrillation compared to those without. Some of that is a little bit hard to tease out because there are people who have AFib because of other heart problems, other medical problems, and those may be what's impacting longevity. But if you adjust for all of that, there does still seem to be some risk there. Now, how do we diagnose atrial fibrillation? Most typically, AFib is something we see on an EKG, and we're going to go through some examples of these. There are cardiac monitors people can wear, something called a Holter monitor, which is typically 24 to 48 hours. And there are longer term monitors, things you can wear for a couple of weeks, sometimes a month at a time. There are home monitoring devices that have become increasingly common and increasingly useful. The Apple Watch is the most common of these. And a device called the Cardia, made by a company called AliveCore, is something that a lot of our patients are using and can be extremely helpful. And there are some other technologies in along those veins. Sometimes AFib is detected on implanted cardiac devices put in for other reasons. So in my field, we also put in pacemakers, which keep the heart from going too slow. Well, they have electrodes within the heart, and they can detect abnormal rhythms very well. Implanted defibrillators similarly treat different types of abnormal rhythms, can detect and tell us about atrial fibrillation. And there's a type of implanted heart monitor, or what we call an implanted loop recorder, that can be used for diagnosis of AFib or diagnosis of other rhythms that may come and go. Now, these are samples of what an EKG looks like on the top in normal rhythm. And you have at the very left-hand side of the screen something labeled P, and there's a little bump there, and that's called the P wave, and that's the activity of the upper chambers. The next sharper deflection, which has three components, is the activity of the lower chambers. And you're going along, and there's a nice regular cadence to this. The bottom strip shows atrial fibrillation. So starting with the big sharper signals, that's the lower chambers beating at an irregular rate, and the timing between each one is different. In between, you have this very chaotic, raggedy activity, which is instead of the nice organized P waves of the upper chamber rhythm, the more chaotic activity of atrial fibrillation in the upper chambers. And here's a real example of an EKG in atrial fibrillation. This is really the most accurate diagnostic test for atrial fibrillation. And if you look at the EKG, there are a series of numbers and letters on it, Roman numbers 1 through 3, AVR, AVL, AVF, and then V1, V2, V3, 4, 5, and 6. And what those represent is different vectors. So we're looking, the heart's activity generates this electrical signal that creates the deflection on the EKG. But when you look at the heart from different angles, you may see more or less of that activity. And that's if you think back to high school math and vector calculus. If a wavefront is coming towards you, you see a bigger deflection. If it's moving sideways, you see less. And what's important here is if you look at, say, lead V1 across the bottom, you see a lot of that chaotic atrial fibrillation activity. But if you look at lead 1 in the top left, you really don't see it that well. And when we get to some of the other monitors, it's important to remember we don't always see the AFib activity in each of these leads, so-called. Now, the EKG is, as I said, our best diagnostic tool for AFib, but it's a snapshot in time. This is recording 10 seconds or so of the heart rhythm while the patient is hooked up to this machine. Some people have AFib that comes and goes. Somewhere between 25 and 60% of cases of AFib are of that nature. And if you don't happen to be having AFib while the EKG is done, we won't know it. And it's not uncommon that we have patients who say, I get palpitations on and off. It lasts for 30 minutes or an hour at a time, and I've never been able to get somewhere and get an EKG done during one of those episodes. So that's where these other monitors that are longer term can come in. So this is a picture of a Holter monitor, which is typically 24 to 48 hours. You have multiple electrodes put on the chest, connecting to an external device, and it delivers an EKG reading that shows the rhythm. And this records continuously for 24 hours, and then there's 24 or 48 hours, and then there's analysis of that to look at what we're seeing. Now, this is cumbersome. You have, in this instance, 5 different electrodes spread over the chest, connected to this external device, and you have to keep this on for a day or two, sleep with it on, you can't shower, and people don't love these monitors. And 24 to 48 hours is better than 10 seconds in the office, but it may not be enough time for us to really have an answer. We've come a long way in terms of monitors, and these are pictures of 2 what we call patch monitors, which can last for up to 2 weeks. So these are there are a number of different brands of these. These are the 2 that are commonly used in my practice. So on the top left, you have a patch that goes on the chest wall. On the bottom right is one that kind of parallels the breastbone. And what you have here are 2 electrodes that are recording basically an EKG between those 2. And in the middle is the computer that or the electronics that record all that information. At the end of 2 weeks, this gets dropped in the mail, goes to the company that makes it, and they get me a report saying, okay, in 2 weeks, this person was in normal rhythm 100% of the time. They had a few extra heartbeats constituting 0.3% of their beats, something like that. Or they'll say, yes, we saw atrial fibrillation, 5 episodes totaling 12 hours total, or AFib was there the whole time and can tell us about the heart rate during atrial fibrillation. So for people who have episodes of palpitations that come and go, but are frequent enough that you'll catch them within 2 weeks, this kind of monitor is excellent. It's much easier to wear. You can shower with it on. It's not very intrusive, not very evident if you're going about your life with, unless you're at the beach or wearing a very tight shirt, no one's even going to know it's there. And these can be, very helpful. Now, I mentioned the Apple Watch, which is also a lot of cases of AFib are found through that. It's very helpful. While you're wearing the Apple Watch, it's recording a pulse on the back of the wrist. Now, that's not a very strong pulse. It's not anywhere we normally would check a pulse, but you can have pulsations there. And it's testing by that the regularity or irregularity of the heart rate, of the heart rhythm, I should say, and testing what the rate is. And that's thought to be somewhere in the range of 70 to 85% accurate at identifying atrial fibrillation. As I mentioned, people get extra heartbeats, so sometimes an extra heartbeat or two will throw this off and create a false alarm for atrial fibrillation. And sometimes the pulses on the back of the wrist are just not strong enough, and the device thinks the heart's irregular because it's just missing some of the beats. Now, some models of the Apple Watch also have an EKG or an ECG app. And what this picture shows is someone using that app. So now you have the watch on one wrist recording, making electrical contact with the skin on that hand, and you're touching the stem of the watch with the other hand, and that creates an electrical circuit spanning the chest and gives us an EKG recording, which is what's shown on the bottom there. Now, as I mentioned, the regular EKG that we do in the office has 12 different leads, 12 different vectors looking at the heart. This has just one. And you may not see the activity in as much detail as you want, but if you look at this EKG recording at the bottom from the watch, you can see that it's very irregular. The timing between each of these beats is very different, and that is very suggestive of atrial fibrillation. And in this instance, that's what the watch is saying. It's saying it shows atrial fibrillation with an average heart rate of 118. And it says, if this is unexpected, talk to your doctor, because if you don't, or if you're not known to have AFib and suddenly you find it, that needs attention. So again, the Apple Watch is testing all the time. The EKG app is more accurate, but only tests when you do it. Similarly, there's a device called a cardiomobile. And this is something that a lot of people have. And this is a little device that you hold with the fingers of each hand. And then you've, again, made this circuit that can show one lead of an EKG. There's also a 6-lead model where you hold it and press it against, there's another electrode on the back, and you press that against your leg or your ankle or your foot. And by looking at the different relationships between right hand and left hand and foot, left hand and foot, and combining them, it generates 6 of the different leads of the 12-lead EKG we do in the office. So that can provide a little more accuracy because a little clearer picture, but gives similar kind of EKG tracings that we can look at. This one, again, is intermittent. It records while you're testing, typically 30 seconds at a time to get a good recording. Doesn't tell us what happened 10 minutes ago. Doesn't tell us what's going to happen 10 minutes from now. Nonetheless, an hour from now or, a day from now. So very helpful when people have symptoms that come and go, can record them with this or with the Apple Watch, and we have an additional tool to get information that way. Now, sometimes we want to look over a longer period of time. Symptoms are less frequent, or we're looking for, can be looking for AFib for other reasons or looking for other rhythm problems. There are these implantable loop recorders. So they're made by different companies. This is the one made by Medtronic. So it's a tiny device. And actually, in this picture, the person holding it, I think, has small hands because it really, in real life, looks even smaller than that picture makes it seem. This is a recorder that's implanted under the skin in a roughly 10-minute surgery that one of my partners says has the medical complexity of putting a microchip in a pet in case the pet gets lost. Basically, we numb up with local anesthetic, make an incision that's about the width of one finger, and put the device in under the skin. This records the rhythm constantly, and the battery lasts. They guarantee, this company, this particular model, they guarantee 3 years. We usually see closer to 4. Different models that are on the market, anywhere from 2 to 5 or 6 years. Now, this is constantly recording the heart rhythm, but most of the time the rhythm's normal and the device is small. It doesn't have that much memory, so it keeps deleting what it sees. And that's why it's called a loop recorder, because it's looping through its memory. But if it sees atrial fibrillation, it holds on to that. If it sees a heart rate that gets very slow or very fast, it holds on to that, because those might be things we want to know about. It communicates on a nightly, the device can't communicate very far. It can communicate over a few feet. So on a nightly basis, it communicates through either an app on your phone or a little device you keep on your nightstand, and that sends the information to us or to our monitoring center. And that way, if most of the time it doesn't have anything to say, but if it has a new episode of atrial fibrillation, we learn about it the next day. And this device can be very useful for people who have things infrequently, and can be useful for atrial fibrillation that's rare, people who have an episode of fainting once every 6 months or so. This can show us what's happening at those times. So, to summarize the diagnosis of AFib, we have an increasing number of tools for this. The accuracy of these varies, and it's sometimes a combination of different things that gets us to the right answer. But we see people all the time who've had episodes of palpitations, and sometimes they say, I had this for 20 years and we never had an answer. And then, the Apple Watch came out and I got it and now we know. Or, we did something else. But so we have a lot of tools that weren't available 10 years ago, 20 years ago, to help us see who has atrial fibrillation. Now, as I mentioned at the start of the talk, the number of cases of atrial fibrillation is increasing. Is it just that we're learning about AFib where we didn't diagnose it in all these cases before? That's probably a contributing factor, not the whole answer, but we are doing a better job diagnosing atrial fibrillation and then being able to treat, which is very important. Now, in the management of atrial fibrillation, I'm going to talk about the management broadly, but we're going to focus on a few areas where there have been some advances recently. So in the management of AFib, first off, we need to address the risk factors which lead to AFib. Otherwise, anything we do is less likely to work. If someone's got diabetes and the diabetes is out of control and blood sugars are high, we're going to struggle to control AFib. High blood pressure that's not well controlled. I mentioned alcohol use. Someone who drinks frequently and regularly, we're more likely to struggle. So we really need to take kind of a holistic approach to managing someone with atrial fibrillation. One of the first and foremost things with AFib is to decrease the risk of stroke. As I mentioned, many people have no symptoms with atrial fibrillation, and it can be okay to live in AFib, but we've got to make sure that we do what we can to prevent strokes from happening. We want to control the heart rate to decrease risk of weakening the heart. And ideally, we want to control the rhythm and keep people out of AFib and in normal rhythm, and that decreases the risk of any consequences of AFib, as well as usually decreasing the symptoms. Now, I want to talk a fair amount about the risk of strokes. AFib is the cause of roughly 1/3 of all strokes. And if somebody's had a stroke and we have no idea why, we often look pretty hard for atrial fibrillation as a cause, and that's one of the times those implanted monitors can be very helpful. We've had a stroke, we have no idea why, we put in a monitor, and it's not uncommon to then learn 6 months later that, oh yeah, this person has some AFib that comes and goes. Didn't see it when they came in the hospital with their stroke. Maybe it happened a few days before and led to that, but that is important to learn about. The strokes related to AFib also tend to be quite severe. Strokes can happen for other reasons too. The ones from AFib tend to be more debilitating and more likely to actually be life-threatening. Now, for an individual with AFib, the risk of stroke averages roughly 5% per year. And if you watch much TV, you see ads for some of the medicines we use to treat this, and they'll tell you the risk of stroke is about 5 times higher if you have AFib than not. But the risk is actually very individual. The risk increases with age, increases if you have some of these other medical conditions listed here, diabetes, hypertension, coronary disease, or peripheral vascular disease, where there's impact on the blood vessels that tells us you're more likely to struggle with a small clot, a history of congestive heart failure, or any other history of strokes. Those all tell us the risk of stroke is considerably higher. Now, why do these strokes happen? Again, when you're in AFib, the atria, the upper chambers of the heart, aren't pumping well, blood's not moving quickly, and will tend to clot. The place where clots mostly form, this is this picture at the bottom, the left atrium, the left upper chamber of the heart here, has this side area called the left atrial appendage, and it's very irregularly shaped. Blood can only get in and out in one area, and the surface of it tends to be very rough. And for all of those reasons, this is the part of the heart most prone to having clots forming. So any clot that forms in there can then make its way out of there to the rest of the circulation. And that's how strokes from AFib happen. So the anticoagulant medications make it harder for blood to clot, harder for these to form. And these are the medicines also referred to as blood thinners. Warfarin has been around for a long time, and for many years that was really our one option for this. Coumadin is the other name for it. There are newer medicines, Pradaxa, Xarelto, Eliquis, one called Savesa, which is used the least. It's actually a pretty good medicine. It was the last of these to be released, and it just hasn't caught on as much as the others. But these medicines have really largely supplanted warfarin. Warfarin is still used, but these others are used much more. They have a more predictable action, so they're easier to take, and they don't require monitoring, which warfarin requires close monitoring. These medicines, you take at a certain dose, they work pretty well. They are all expensive. They're all, unfortunately, at this point, none of them are generic. They're all branded medications, and they're all expensive. These are among the first 10 medicines that Medicare is going to begin negotiating prices for. That takes effect in 2026. I don't know what the impact will be. Some of them should be reaching a generic status, maybe in that same time frame. So, some relief in sight there. But these are, really one of the mainstays of therapy. Now, not everyone can take these medications. They work by preventing blood from clotting, which is how they help prevent strokes in AFib, but sometimes you need your blood to clot. And there can be bleeding complications of being on these medicines because you might have a tiny ulcer in the stomach that, instead of some microscopic amount of blood or very little blood, now bleeds more significantly. If there's any trauma, what we worry about most is head trauma. If someone is in an accident or falls and hits their head, you increase the risk of bleeding into the brain, which is obviously very dangerous, especially in the setting of a medicine that's preventing your body from clotting and controlling that bleeding. And there's not great, really clinical data on this, but there's things talked about that roughly half of people prescribed these anticoagulants stop taking them within 2 or 3 years because of bleeding issues. I don't know if it's that high, but I see a very a subset of general population, and this is a problem for a lot of people. Now, blocking off that left atrial appendage where clots mostly form is another option we have to decrease the risk of stroke without needing these kind of medications. And there are implanted devices called the Watchman and the Amulet that we use for that purpose. It can be done with cardiac surgery too. That's done much less commonly for its own reason. But if someone has atrial fibrillation and they're going to go have a valve replacement surgery, while the surgeon is there, they can also close the left atrial appendage. But these devices, the Watchman and the Amulet, these are pictures of them, Watchman on the top left, Amulet on the bottom right. And these are devices that we implant in a catheter-based procedure. So we're going with a catheter through veins in the groin up to the heart, getting the device positioned in that left atrial appendage and placing the device there. So in the case on the top left, you have the Amulet, which is a wire framework with fabric over it. Blood can flow through the fabric like when you make your coffee in the morning and it flows through the filter. But any clot that forms out in the left atrial appendage can't get out. Now, these devices are not perfect. Sometimes you get them in place pretty well, but there's a little bit of leak because the device is round, but the opening of the left atrial appendage may be more oval. And sometimes a clot can form on the surface of the device. Gradually, the body heals over the surface of these devices, and that risk decreases. But so when we put these devices in, we can almost always cut back on, we use some blood thinners, but usually weaker. We can cut back on those. And these have been shown to work about as well as taking blood thinners at decreasing the risk of strokes related to atrial fibrillation without needing the same medications long term. The Watchman has been around for probably 10 or 12 years. The Amulet device was approved by the FDA, I think about 3 years ago, and they both are very good devices that have had, advances over time and do a good job at addressing this problem. Now, talking a little more generally about the other treatments of AFib, as I mentioned, one of the risks is a fast rate in the lower chambers, and sometimes we just focus on that. Sometimes we can let the AFib be, but control the heart rate in the lower chambers. There are medicines we use for that, most of which are medicines that were developed actually for blood pressure control, help to control the heart rate too, and can be very safe over the long term. Sometimes we cannot get the heart rate controlled enough, and we can do a procedure called ablation, where we go in and destroy the electrical connection between the upper and lower chambers of the heart. Now the upper chambers are in AFib, but that activity doesn't communicate to the lower chambers, so they are not driven to beat too fast. They need something to tell them how to beat, so along with this, we put in a pacemaker to control the heart rate in the lower chambers. There are some recent advances in pacemaker technologies that make this a better option than it was, say, 10 or 15 years ago, both in terms of something called a leadless pacemaker, which is a device where the whole pacemaker sits in the right lower chamber of the heart, and there are less risks associated with that over the long term. And then some other differences in how we position pacemaker wires to deliver energy to the heart in ways that make the heart beat in a more efficient way. So that's not our top choice for management of atrial fibrillation. We'd rather keep someone in sinus rhythm, and sinus rhythm is the normal rhythm. We'd rather preserve that in most cases, but sometimes this other process, the ablation with pacemaker, it can be a better approach. Now, I want to talk for the remainder of our time about how we control the rhythm itself, how we keep people out of atrial fibrillation and in normal rhythm. Now, one of the options for that is medication, so-called antiarrhythmic drugs. These are some very specialized medicines specifically for treating AFib and some other abnormal rhythms. They all have a risk of causing life-threatening abnormal heart rhythms. So we have to be very careful in how we use them. Some of them have other serious side effects, and they may have side effects that are less dangerous but can be very bothersome. So sometimes these at the bottom are the names of the most commonly used heart rhythm medicines for atrial fibrillation. Now, one interesting thing is that the first one I listed, called Multac or dronedarone, is the newest one. I think it came on the market in about 2009 or 2010. All of the others have been around for decades. So they're not overwhelmingly expensive, which is good news. They're not as good as we'd like in terms of how well they work and what their risks are, but there's not a lot of development going on among pharmaceutical companies in this area. It's very tricky to tinker with the heart rhythm and have only benefits without risks there. So we have the medicines we have. They work for some people. They don't always work, and they have some limitations as an option. Now, sorry, my slides jumped ahead. The other option for us to treat the rhythm is this procedure called ablation. Now, ablation, as a general medical term, refers to any selective destruction of tissue within the body. You can do ablation for tumors. You can do ablation for other issues. In the case of the heart rhythm, ablation involves very selectively scarring over part of the heart that's behaving abnormally, causing the abnormal rhythm in question. Now, this is a picture of the left atrium. Atrial fibrillation involves the two atria, the two upper chambers of the heart, but it almost always starts in the left atrium. And this is a view looking at the left atrium from the back. And there are four veins called the pulmonary veins, bringing blood from the lungs back to the left atrium. And the way these veins develop, there's abnormal heart muscle stretching out in the walls of these. And that muscle is where AFib gets triggered in almost all cases. And we don't know why this is. As I said earlier, the cause of AFib is often not clear, and we don't know why the muscle in these veins starts acting up in one person but not another, but it does. And we know that electrically isolating these from the rest of the heart can help eliminate the atrial fibrillation. So here's kind of a cartoon of that, and this is the kind of things that we're looking at when we do an ablation. We do this by getting catheters into the heart, again, going through veins in the groin. Moving our catheters around, we can create these geometries of that chamber. And this is a similar view of the left atrium, the left upper chamber, looking from the back. And you have these four pulmonary veins. In this picture on the left, the different colors have different meanings. The purple area is healthy muscle, and the red is where there's not healthy activity or even scar. Now, in this case, if you go far enough out into these veins, you get past where the muscle ends, and that's why it turns red there. So in this case, we're giving a series of burns, and each of these salmon-colored dots represents one of these burns, and we're doing sort of a connect the dots to create this ring of scar tissue around the mouths of these veins. And the one on the right just shows it without the colors, maybe a little easier to see what we're doing. So we're creating this ring of scar so that the muscle in the walls of the vein cannot affect the muscle in the rest of the heart and can't trigger AFib anymore. Now, in someone who has more advanced case of atrial fibrillation, in it more persistently, has more structural damage to the heart, we may need to ablate more. So this is a similar picture, again, looking from the back, and you're seeing a series of burns around the left pulmonary veins entering the left atrium and around the right. And in this case, there's a lot more of them. It's a lot bigger area that we've got to target. And in this case, we also wanted to target the back wall of the left atrium between them. So that's what these other two lines are. And we're kind of trying to eliminate the activity in that whole area. And this is looking at that from kind of a side view. And this is how our catheters look on this screen, and the different colors of the ablation dots tell us different things. And this arrow is telling me about the force my catheter is applying against the tissue. So a lot of technology at work here to enable us to do this with just some catheters we've put in through veins in the groin. Now there's something called cryoablation, which uses cold rather than heat to create scarring. And in this case, it's delivered with a balloon that tries to ablate this vein all in one shot. So there's some efficiency to be gained there, but maybe less flexibility because I can't put the balloon everywhere I might want to in the heart. Now, ablation can be done surgically. Surgeons in St. Louis years ago at Washington University developed something called a maze procedure, where they basically said, well, if we cut the atria up, the two atria, into little bits and sew them back together, we can disrupt the propagation of these electrical signals and get rid of AFib that way. So they created this maze surgery, which actually works quite well, but is a big, big surgery with considerable risk to it. Now, ablation doesn't always work. Sometimes the tissue we've ablated recovers. The gaps, the different lesions might be too far apart. They might just not be doing enough damage to what we're trying to target. The success of a single ablation for AFib is probably in the range of 60 to 80% with the newest tools we have. It's a long procedure. The radio frequency, the most common ablation where we're burning, each of those burns can range anywhere from 4 to about 45 seconds. And one procedure might include anywhere from 70 to 200 of those burns. And in between each one, you're moving, getting in good position, then delivering another. This takes a while. The cryoablation, that freezing, as I said, the lesions cover more ground, but you typically give only one or two for each of these veins, but they're several minutes long each time, and you may have to wait a few minutes in between for everything to warm up before giving another one. So it adds up to a lot of time. There are also risks with ablation. A small percentage of cases have complications, but some of them are quite potentially serious. Some of the most dreaded involve damage to other structures nearby. And there's been a lot of work over the years to find ways to try to improve on all of these factors. Now, the kind of hot news in atrial fibrillation is something called pulse field ablation. And this is a type of ablation where instead of delivering heat or cold, we're giving electrical current and electrical shocks locally. And those shocks result in disrupting the cell membranes, the walls of the heart muscle cells, and leading to scarring that way. Now, this is something that's been worked at for more than 10 years, but a lot of clinical research over the last 5 years, leading to two systems that are now FDA approved that we're actually using quite a bit. This appears to be faster, and so far the data backs up that it's a faster procedure. It appears that the damage is more permanent, at least theoretically so, and we're still learning about that. But one of the most important things, the sensitivity of tissue outside the heart to these electrical shocks is very different from the sensitivity of heart muscle. And that may decrease the risk of injury to other structures nearby that ablation can lead to. There's a risk of injury to the esophagus with ablation for AFib, and that actually can be life-threatening. There's a risk of injury to the phrenic nerves, the nerves going to the diaphragms, muscles that help you breathe. And if there's injury to those nerves, that leads to shortness of breath. And it appears that with the pulse field ablation, those risks go to pretty close to zero. Now, this is one of the catheters called the Pulse Select from Medtronic, and this was approved by the FDA last December. So this catheter has 9 electrodes arranged in a circle and basically delivers this energy to all 9 of those. So we put this in one of the pulmonary veins, ablate for just a couple seconds, turn it a few times and ablate. So we're sure we've gotten good coverage around the whole vein, and then we can move to the next vein and do the same thing. This is the second system, which the FDA approved about a month later, called Farapulse from a company called Boston Scientific. And this catheter creates this flower look where you have kind of 5 loops, or we refer to them as petals, and they have electrodes on them and delivers the energy that way. And this shadowy kind of light blue represents the field generated by that creates the actual ablation lesions. This catheter you can also put in what they call a basket formation, where it's just kind of a big round, almost like a ball, and ablate that way as well. Now, this is a similar one of those maps from an ablation done with one of the pulse field ablation systems. So again, looking at the left atrium from the back, and purple is healthy muscle, and the red is out the veins where there's already no activity. For the moment, ignore these little lines. So this is showing what the atrium looks like before we start. Now we've gone and ablated, and all of these circles represent places that catheter positions where we've ablated. And afterwards, repeating that map, we have scarring encompassing all of this area within the pulmonary veins and even stretching out a little farther. And probably our lines were not quite accurate of where we felt that the catheters were. And this kind of ablation is still a number of lesions, but they're each much quicker, seconds at a time. And this is a much quicker procedure. Now, how well does this work? So the biggest trial to really compare this to our standard ablations was that Farapulse, the second system I showed, similar effectiveness. So at 1 year in either arm, roughly 75% of people in the trial free from AFib. The procedures were about 20 minutes shorter, ranging close to 2 hours with the conventional procedure, an hour and 40 minutes or so with the newer procedure. So that's an improvement, but it's not earth-shattering, but it's an improvement. The safety was similar. The safety overall was similar, but there were no incidents of narrowing these veins leading to a problem there, no incidents of damage to the esophagus, and no incidents of damage to the phrenic nerve going to the diaphragms. Now, in terms of this pulse field ablation, those are, as I showed, 2 systems. There's a number of others, either in clinical trials or recently completed trials. And we think that as we learn more about this technology, the effectiveness is likely to improve. And already the faster procedures and the improved safety make this an option for increasing numbers of patients who we might have been concerned about doing an ablation before. So to wrap up, AFib again is a very common and potentially very dangerous condition. It can lead to strokes, can lead to weakening of the heart, and can lead to a lot of different symptoms. We have advances in diagnostic tools that help us identify AF sooner and treat appropriately sooner than we ever could before. And we have ongoing advances in treatment that have led to new and better options for a large number of patients we take care of.
And with that, I would like to say that we appreciate you for joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to the survey has been added to the chat for your convenience. A special thank you to Dr. Sussman for dedicating your time and expertise today. If you have any additional questions or comments, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499 option 3. And that concludes today's webinar, and I hope you all have a great day.
Thank you.